think there's a couple things you have to think about when you're thinking about bispecifics versus CAR T. One is, as you point out, right, the ease of delivering therapy. Like obviously an off-the-shelf product is going to be faster. But the other thing is when you think about particularly follicular lymphoma population, right, and here in Olympia 1 we're looking at an upfront population. So our tolerability of toxicity is actually going to be really, really low as opposed to either a large cell population or a relapsed refractory population. So you want to look at not only kind of the ease of delivering therapy, which in follicular, we do probably have time, but we also want to kind of limit the amount of exposure to drug and toxicity, particularly for an earlier phase follicular lymphoma population. Like big picture, I think probably within the next several years, we're going to actually move away from chemoimmunotherapy in follicular lymphoma as we learn how to incorporate, bispecific antibodies, figure out who are the correct patients for CAR T therapy, perhaps use other immune modulatory agents. So I think big picture is we're moving away from chemoimmunotherapy, but particularly in a follicular lymphoma population, particularly earlier lines, our desire for toxicity ends up being really, really low. So I think that's actually going to drive, at least in that space, kind of where we end up going in terms of T-cell engaging therapies. It's probably going to be a combination of things. One is, while we have we'll see some updated data of other bispecific monotherapies. We'll get a better sense of the durability, because I think for right now, a lot of us are still, particularly in something like CNS lymphoma or large cell lymphoma, we're thinking, okay, we got to get to cure, get to cure, get to cure. So we just have enough follow-up on some of those CAR T studies to know that there's a plateau and think there's probably a cure for action. It's probably not as high as we initially thought it would be, but it probably exists. And I think we don't know that yet with bispecifics. I think the thinking between of studies like Olympia 1 and some of the other earlier lines of therapy studies for bispecifics, the thought is, I think if you treat people earlier, before they've been exposed to bendamustine in particular, perhaps their T cells are more robust, perhaps you'll get a better and a more durable response because those T cells haven't seen chemotherapy, right? There are more of them and they're probably more robust. So I think with the reason to think about the sequencing is just because we don't have that follow-up with bispecifics that we have with CAR T cells. At the end of the day, perhaps if we pick the right drug, the right combination, the right line of therapy, I think there could be a fraction of people who probably don't need to have it followed up with a cell therapy. On the flip side, there's also the whole emerging field of allogeneic, off-the-shelf, NK activating CAR or other cellular therapies that are even kind of earlier in lines of development, right? Just phase 1 studies now. So how those will completely ultimately disrupt the paradigm, we have no idea. So then if you have both a bispecific antibody and a quote off-the-shelf cell therapy, that's a whole other decision tree we're gonna have to figure out, right? One of the reasons I like Olympia 1 is because I think it is really interesting to take this into the frontline space, and there's not as much, there is a lot less data, and I think that particularly with this therapy, because the response rates in ELM1 and ELM2, their kind of relapse refractory studies were so high, I do think it's really interesting rationale to try to take this particular antibody that does seem to be relatively potent and kind of move it into, again, earlier lines when the T cells aren't as beat up. Maybe you could hypothesize because they haven't seen as much therapy, maybe the hypogammaglobulinemia and the infections will be less. So I think that what I like is actually the idea of just taking a swing here in the upfront population, because while it's maybe you might think of it as kind of a big swing, if you have a really potent drug and you have the ability to avoid chemotherapy and have a very fixed duration of therapy, right? Patients stop after 8 cycles of therapy here, that maybe that's a really interesting way to disrupt the space and change the paradigm in follicular lymphoma.